Okay, so clinical reasoning. Let's begin with the definition. Now, you'd be forgiven for not knowing the definition because a recent meta analysis has said there were 110 individual definitions of CR. So let's just muddy the water and give you a 111th one, all the ones. So I think clinical reasoning is a cognitive process, so it's in the brain of acquisition, getting some info, labeling things the right importance with triage, and that's both intellectually important and emotionally important. The second thing is the stuff that we as academics and doctors and students often forget. The brain cares how much it cares about the information, and we need to utilize that. And then relevant response generation. Are we modeling the right response to this data? Because there's no point knowing it if you don't know what to do with it. And then the modifying ecosystem, the things within you and without you that affect your decision making. So, which egg are you today? I'm not sure which one I am. Is there a tired egg? I'm one of those. So, let's talk about this limbic salience. Awe is one of the most powerful means by which we can impart memory into the system, other than terror and fear. Awe reminds me of a quote that I learnt in high school. If you want to build a ship, don't drum up people to collect wood and assign them tasks and work, but rather teach them to long for the endless immensity of the sea. It's about inspiring, right? These are the best communicators, these are the best deliverers of information. So, clinical reasoning, is it important? It's very important. Graeber's study in 2005 was a large study of malpractice and found that in a year in the US, 7.4 million people were misdiagnosed in A&E, of which 370,000 came to severe morbidity or mortality. So why are doctors drowning in this? Okay. Well, the DENS error, i.e. doctor educational need, i.e. a knowledge error, was 22%. And that means that 8 in 10, pretty much, errors, the doctor knew. It just wasn't executed on. So 43% was found to be a processing error, so the information came in and wasn't processed and acted upon. And then 35% was an extrinsic error, a really busy environment, a difficult environment, time of day, all that kind of stuff. So we've got to be aware of our heuristics and our health for processing errors. And there's so much that can affect you extrinsically. Basically, the whole world on a spectrum can affect you. But I like to think about Sapolsky's scale. So this is the neurobiologist from Stanford called Robert Sapolsky, who's done a lot of work on why we think and why we behave the way we do. He's brought out a few books that I would fully recommend to you, and his dog is gorgeous. He talks about why you pull a trigger. So if you saw someone coming towards you, you were on a street, you had a handgun, and you decided to pull the trigger, why have you decided to pull that trigger? So he uses a scale of time. So the seconds before you pulled the trigger, what was happening in that brain? Was your limbic system in charge? Were higher cognitive processes in charge? What was the spectrum of who was in charge there? In the minutes before, fatigue, stress, time of day, what you ate for lunch, how's your blood sugar? The days before, if I do a serum sample of you, what's your noradrenaline levels? What are your cortisol levels? What's your thyroid function? And how's that affecting your ability to decide things? The weeks before, what's your social biome like? Your relationships with your closest people, your neighbours, your kids. How's your partner? Do you have a partner? Are you going through a divorce? Are you caring for someone? Like, this is a huge problem for our patients and for us. Are we taking a social history on ourselves? Years from when you decided to pull that trigger, how was your childhood? What trauma have you experienced? What ACEs have you experienced? What was your in utero environment like? Was it enriched? Was it impoverished? And how does that affect your brain and its neuroplasticity and its decision-making apparatus? Spoiler alert, it does a lot, and a lot more than we give it credit for. What about your ancestry? I.e., what are the cultural norms in self-defense, in pulling that trigger, in owning a gun, in how you perceive men, how you perceive that demographic? And then broader, the millennia, what is the genome you're carrying and its epigenetic expression of your phenotype? What have you had passed on to you from countless ancestors with their varied environments that have led your brain to be conditioned in the way it is? In short, we have no idea why she pulled that trigger. And we are teaching people to behave in a certain way, to reason through a process. And there are so many extrinsic modifiers that it is nearly impossible. So let's just take a humble moment for that, right? Let's just take a humble moment. Let's look at the floppy disk of memory. So we've got short-term memory, long-term memory. There's lots of types of long-term memory. I'm not going to go into it. Our job is to give people good short-term information for their memory in a way that makes sense so that they can encode it into the long-term memory with the scaffolding of our help. That's our job. To get from short to long term, we can use Miller's law and Baddeley's model to really good effect. And Miller's law talks about the chunks of information for your short-term memory, and it is always way less than we assume. Long lectures should go the way of the dodo, in my opinion, because they're only cost-effective. They're not good in any other way. Baddeley's model talks about dual stream effect, which we'll come to when we talk about something in a second, but spoilers there. This typical slide that you saw in medical school. Dense, rich in content, but terrifying, right? That is not respecting Miller's law or Baddeley's model in any way. To go from short to long term, we use two structures. Let me get my pen out. We use the hippocampus, which takes information in from here. Okay, ooh, I was looking for a little pointer. We use the hippocampus here, and then immediately rostral to the hippocampus that I've taken out of this prosection but is here in the complete region, you can see the entorhinal cortex, the ERC. And the ERC is the superhero of reasoning and education because it is the triage nurse. Whereas the hippocampus receives this information, it's the entorhinal cortex that makes a determination as to whether or not it's going to go into your long-term memory. So the ERC should be our best friend and our worst enemy as an educator because it is the gatekeeper to the cortex. This is Verdun. Verdun's lovely. It has a checkered past, but there we go. And this is some Duolingo French for you, which I don't have time to ask you about. So it's the illusion of double, which is seen in Capgras syndrome. So in Capgras syndrome, the patient believes that their loved ones have been replaced by an imposter. It is a neuropsychological delusion with a definite anatomical lesion. And we can use Baddeley's model to discuss this. So let's say you see a cup. Your occipital lobe receives cup information, sends it to the occipital association cortices, which realizes that this raw data is a cup, and then the occipital lobe sends that to the cortex to determine what to do with the cup. It sends it with the upstream, okay, or the superior stream, and this stream is intellectual. So all of these parameters, I think it's a cup is tea. So you can now make a plan cortex for how to make a cup of tea. But this lower stream, this inferior stream, is the emotive stream. A cup, this is my favourite cup. My mum gave it to me and sadly she's not with us anymore. I used to have lovely cups of tea with my gran who's also no longer with me. Or I got this cup from a trip to Dublin with my partner on an anniversary. I love this cup. And tea just tastes better in this cup. You need both streams for memory. Capgras is the loss of the inferior stream. So you say, well, that person looks a lot like my wife. She's got freckles in the right place, same skin tone, same skin colour, same eyes. But she doesn't feel like she's my wife, so therefore she's an imposter. So the neocortex assumes that there is a dehiscence here. So because it doesn't have the emotional lower stream backing it up, it thinks there's an imposter. For memory, we need both. And we do not focus on the emotional impact enough in medical school. Can't talk about memory without talking about this guy who recently passed away, Daniel Kahneman, Thinking Fast and Slow, Dual Process Theory. System 1 and System 2, two different ways of thinking. So your System 1 is your fast thinking, it's your pattern recognition, doesn't take a lot of energy, it's efficient, it's how most doctors work most of the time. Chest pain in A&E gets OBS, a 12-lead ECG, bloods with a TROPS and a chest x-ray, okay? Number 2, okay, they're all negative. Oy, so now I've got to turn my brain on and think with an open mind. Could this be variant angina? Could this be hyperventilation syndrome? Could this be a DKA? What is this, right? I want you to think about illness scripts now. So illness scripts and schemas are how we think about things, conditions. So let's say I see here about a tremor, boom. So thyroid. So how is this being set in my system? Well, imagine these columns or scripts. The pathophysiology of thyroid disease, how it presents, its investigations and its management. Okay? That's an illness script. The more I see thyroid disorders, the more I read about thyroid disorders, the wider this gets and the deeper this gets. Okay? And that's how I'm becoming more expert. I'm learning more about the disease and the script's getting wider. But real expertise comes in the lateral processing, the connections between different illness scripts. Okay? So all of these cause tremor. Some of them cause similar tremors. Some of them have common demographies together. So essential tremors, often those patients are the demo where they have COPDs, frequent exacerbation, so they're having a lot of SABA use. So is it an essential tremor? Is it salbutamol use? What about the patient who's on lithium for the mood disorder, right? Very important. So these lateral connections between scripts are more effortful early on. You're keeping an open mind, so they do protect against biases, but they are very energy intensive. They're tough because you're keeping multiple things at mind in one go, so it's hard. There's a lot of iceberg effect here. There's a lot of subcortical processings going on that we're not deliberately thinking about, okay? So we're asking the question basically about how can we teach a subconscious process, which could be multiple textbooks that only scratch the surface really, right? But we're also asking a question that people have asked since the dawn of time, which is how do you become an expert? What's the route to mastery of all topics? How do you get there? There are two people who have specifically published on this in a lot of detail. The Dreyfus Model of Excellence and Robert Greene himself, more for lay people. He wrote this book called Mastery, okay? And he came up with the ACE approach. You start off as an apprentice. Then with the right stuff, you become a creative practitioner. And if you're lucky, you become an expert. So if we make the train line here for the approach, let's begin. Apprentice, sort of clinical years of med school up to SHO. Creative practitioner is an SPR, and expert is post-CCT, basically. And the apprentice model down here, these are the people who are very tight with rules and regulations. They're going to do a full history on every single patient. They're going to do a full physical exam on every single patient, right? Repetition in a safe environment, closely monitored, has to occur, okay? They also have these things called threshold knowledge, which is really important evidence-based knowledge to move the needle forward. Ceftriaxone is a penicillin, therefore I can't give to people with penicillin allergies. Threshold concepts are the points at which you can go off a cliff, okay? So these are things that are vital, but they often lead to avoidant behavior because they're scary. And if we're not aware of our own personal threshold concepts that we tend to avoid, we cannot progress, okay? So you need to be aware of them. So to model an apprentice and help them, we model conditions that are unsafe in safe environments. So for example, model resus and simulation, so we don't have to put them in there as medical students. We scaffold for safety. So if they are coming to resus, they're coming with a senior doctor who is talking them through the process, who is giving them a hands-off approach at the start and slowly scaffolding their competencies, okay? The threshold knowledge we give them has to contain a real robust evidence base to be acceptable to them. And we warn them of threshold concepts so they're ready to spot the things that they're going to avoid. We accept that all doctors have them multiple a year and it causes avoidant behavior. For example, if you're rubbish at ABGs and you've had a few bad experiences, you can get a chip on your shoulder and then you can avoid doing ABGs on people who need them on wards because you're afraid. So the patient's not getting the best care, okay? Being able to talk about that is really important because you tell your supervisor and they can put you in ITU where you can do 20 ABGs in an hour, right? And you can just get good at it and then it's fine, right? But you need to know it because otherwise you'll stay quiet, avoidant, you're embarrassed and it will cause a problem, right? It's really important that. When you're in the creative practitioner, you've been doing it for a few years, you're starting to look at a lot more variables and you're doing that with the open mind of the lateral linkage. So you've got your illness script, you've got these schemas that are deep and they're wide and they're connecting laterally to others. So I see tremor, I'm thinking thyroid, but it's laterally also linking to other stuff because this patient is on a lot of inhalers. This patient is on lithium, so it could be more than one thing, okay? They're trusting themselves to experiment, but the flip side is Dunning-Kruger. So they're still at the point where they may risk premature closure. I know exactly what this is with a cocky swagger. And the issue is that expertise comes from experience of making big mistakes. They haven't got there yet. So they need high fidelity simulation using that model of multiple different modalities coming in to make sim as well multimodal as possible. Confounders with MDT heuristic spotting, okay? So multiple people bringing confounders into the plan that they came up with. What if this happened? What if they had this instead of this? What if this lab was different? What if there was this MRI finding? Then what would you do, okay? Heuristic spotting is also really important. I think you did this, or which of the following heuristics do you think were at play and what you were doing there? Why were they at play? And what would you do differently if they weren't at play? Is really important, okay? Because it's making them think after the fact. Debrief should include biopsychosocial of the patient and the doctor, okay? Including this effect of not just the intellect of what did you do and why, but how did it make you feel? We think it's wishy-washy, but we have an enormously important limbic system within us. Having a visceral reaction to the limbic system is your limbic system, right? So it's really important that you talk about both, because memory and learning occurs in both zones at once, okay? Threshold concepts remain an issue for every doctor, so seek them and work out what's going on to confront the emotional salience around that, okay? The expert. These people are in flow state, and that comes from an ease of being in a state where you have reflected on and metabolized the errors that you have made. It's called fuzzy logic because a lot of their work is the iceberg effect where 90% is below the surface. I.e., if you asked a consultant who's an expert, why did you do that? They'd have to sit back and go, because of this and this and this and this and this. And at that point, you're in post-hoc rationalization because actually a lot of those decisions have been made subcortically because those lateral nets are so well developed that they just fire. And so you're not actually critiquing the data. They're brilliant in the basics and they are clear in chaos, says Secretary Mattis about experts. So how do you get there? By taking every error as a trailhead opportunity. You metabolize it and reflect on it properly. You go to MDTs and M&Ms and you have groups critique what you are doing, which takes humility, right? Peer review of novel quips at conferences are also very important, and teaching at grand rounds. So exposing yourself to multiple other experts, critiquing, challenging, and being humble about it, which is often not possible for a lot of doctors. So, speaking on that, Erickson. The role of deliberative practice in the acquisition of expert performance. What percentage of doctors become an expert? He says it's 10%, which is kind of bonkers. He says that without adequate feedback, efficient learning is impossible. Improvement only minimal, even for highly motivated subjects. And the fact that medical professionals stop improving once they reach an acceptable level is concerning because of the need to grow in medicine, okay? So how do we improve clinical reasoning then? How do we do this stuff? How do we go from this apprentice to this expert, and how do we help our students? Well, I did a systematic review in med school, and I've looked at the literature since then and I've added to it, okay? And I've come up with these 4 pillars. So Dan's 4 pillars of clinical reasoning. We've got feedback, organized group activities, bias analysis, and schema generation. So if we begin with feedback, there's 3 tentpole features here, and the first is how we give the feedback. And oh, please, if I impart nothing else to you, Gottman's interpersonal rules. Gottman are a husband and wife, PhDs, who have a lab in the States, and for about 40 years now they've been looking at all sorts of relationships, romantic and otherwise, conflict resolution. And they preach that negative emotions are so much more powerful than positive emotions in the average. So there is a golden rule in conflict and in relationships and in discussions, in communication with another human being, 5 to 1. 5 positives for 1 negative to be in the black, otherwise you're in the red. So when you're giving feedback, if you're saying you could have done this, you could have done that, you could have done this, you could have done that, even the Dalai Lama will be in floods of tears, okay? Most of us have spent most of our career receiving bad feedback with very poor evidence base. And it sucks. And good feedback is very hard and very important for learning. Miller's law. So not only the positive to negative ratios, but give them less content. Give them less content. 4 to 7 items in the short-term memory. So my amalgamation of this is Pearl, Pearl, progress, progress, Pearl. So even the negative is a progress point. Okay, so it's framing a negative into a positive, which is positive psychology and just works. Okay, so I give a Pearl, you give a Pearl, student. I give a progress note, you give a progress note, and then I finish with another Pearl. So I've given you 2 Pearls, like you've done really well here because of this, this, and this. You know, really good rapport with the patient is your classic one, and you took an excellent history. Progress note, your cannulation was rubbish. But obviously you wouldn't say it like that. Time is irrelevant. You don't have to give immediate feedback. You just have to give feedback, okay? So you can give it a week later. It's fine. But write it down. Don't give it orally. Write it down. We are trying to respect the entorhinal cortex and it needs something written down. That's really important. Theodore Roosevelt said, no one cares how much you know until they know how much you care. This is why my mentor in medical school, shout out to Dr. Amy Burbridge, starts with ICE every history that she takes because she wants them to know that she cares before she takes the history. So, organised group work. So, 4 little pearls here. Group working is really important because it makes it easier for you to be in your zone of development. The proper good development. You feel comfortable, not out of your comfort zone for many reasons. When you have near peers and an expert scaffolding, it makes it a lot easier to make those lateral links. You're in a growth mindset much more easily. Ambiguous cases are really important in organised group work. It forces system 2 on everyone. And you're sharing working memory here, which decreases that cognitive load. So Miller's law does not stay static in a group. It's spread among the group if you spread the workload properly. And you can do that with role assigning. So anchoring, who's the lead, biasing using certain checklists that we'll talk about, who's the challenger, who's going to refute the differential, and who's the documenter that makes things like flowcharts and problem lists. The TWED checklist is a way that you can sort of slow down your thinking. So what's a threat? Times 2. Threat to the patient and threat to my GMC if I miss it. Saying out loud, what else could it be? Challenges the group to slow down and think. What's the evidence for this differential? What's the evidence for this? What's the evidence for that? Which one's better? And then openly saying, what doesn't fit here? Says someone in the group. And then someone else says, well, it's been on my mind that actually this thing doesn't fit based on our plan. And then we all go, ooh. Really important. Okay? Einstein says that wisdom is not the product of schooling, but of the lifetime attempt to acquire it, often in dialogue with others. I love that. Right. Bias analysis now. So bias analysis, 4 points. Number 1, think out loud, Ed Sheeran. Okay? By thinking out loud, you vocalize biases. Everyone else is better at picking up your biases than you are. Right? We have a bias for not picking up our bias. What's it that 90% of people think they're above average at driving? We're not great at knowing how good we are. Number 2, slowing TWED. Okay, so slowing down your approach with the TWED checklist as we've talked about before. Expert modeling. So this is the best way to teach heuristics because there's data to show that if you teach the different types of biases, patients actually get good at spotting biases on videos, but they don't get better at having their biases checked. The best way, according to the evidence base, for our biases to be checked is that we have seen an expert in clinic checking their biases that has improved patient care. What a surprise that adding emotional salience to something factual makes a difference. That's the best thing. If I saw a consultant checking a bias and they don't go down a certain route and the patient gets a better outcome, then boy do I now believe in bias. That's the thing that we need to model, okay? Distractor lists. So let's talk about the different kind of distractors. Think about the mnemonic fact. Framing or familiar. Familiar being, I saw a PE recently that went really bad, so now every swollen limb is a PE because it's familiar to me. Anchoring effect and your affect itself. What mood are you in? What's going on in your life outside? What's the context? 20 patients to see on the corridor, loads of patients to clerk in, you're behind, you've got loads of admin on EMIS, EMIS in general. And the time of day, super important on your reasoning. Here's a quote on bias analysis. Unconscious bias is like a fingerprint. It shapes our perceptions and decisions without us even realizing it. Then the final one is good old schema generation. We love schema generation. So schema are your illness scripts, these columns. Just being aware of schemas and saying to students early, having a talk like this and saying you're now generating schemas for conditions, and the parallel processing will come a bit later, okay? But you need to build these columns now. You've got 300 conditions on the UKMLA condition list. You need 300 columns growing. So let's start growing those columns. Semantic qualifiers are adverbs and adjectives like acute, chronic, focal, diffuse, unilateral, bilateral, that are sort of like hashtags that tag all of these different conditions together to help us with our reasoning to separate stuff and to get more description. The complaint list. So the complaint list, we know a problem list is super useful for schema generation because it's helping you to order your thinking. Confounders as well grow the width and depth of those illness columns because they're introducing difficulties. Okay, so what if this thyroid patient wasn't okay on that dose? What would you do next? When would you follow up the bloods? When would you say, okay, that's not working, so what if it's not thyroid? What's the differential for this? That's growing that illness script. We've talked about high fidelity simulation, so increasing the amount of modalities increases obviously the data that we have for these illness scripts. And then GIGO is garbage in, garbage out. If we're not giving them evidence-based options and telling them where to go for evidence-based solutions, then they're not generating useful scripts. The next one is mapping. So this is out of Stanford. This is a way to sort of map your columns and then go laterally in those columns and draw out connections. It's worth a 1 hour talk in and of itself, so I'm not going to cover it now. And then applying preclinical content is important. If they've got heartburn, talk about parietal cells, talk about proton pumps, talk about H pluses and the CL minuses and all of that stuff. It still grows the schema. I got ChatGPT to come up with a schema generation quote because I can't find anything poetically on a schema generation quote. Patterns are the language of the mind, and clinical reasoning is learning to speak it fluently. Lovely. So we've got FOBs, feedback, organised group, bias analysis and schema generation. And what's the keystone? Limbic valence, okay? So we can give good feedback, we can have nice groups, we can analyse the biases and talk about them and generate good quality evidence-based schema. But the linchpin, think about Capgras. You need content and emotional salience in everything you teach. So what's your take-home message? Well, of course I'm going to obey Miller's Law, aren't I? So I'm going to give you 3 little pearls of wisdom to take home with you. And the first one is, clinical reasoning is really valuable and it's evidence-based. There are routes to expertise, and we have growing evidence-based for how to do it. Expertise does not come with hours served alone, which is actually a big issue in how we train doctors in the UK. And the 4 pillars works. There's evidence out there. This is the cutting edge evidence in 2025 for clinical reasoning, and I am done.